And as a reminder, we do record these videos and they are posted on our website following the webinars.
Melanie, should we give it a couple more minutes?
Probably just one more minute.
Okay.
Emma. We have just about 30, almost 30 in here. Before we begin, just a reminder, unless you are presenting or speaking, please mute your microphone so that we do not capture background noise. And our webinar is posted for those who can't make it on our website later today. And please add your name and organization in the chat box so we know who's present as well.
All righty, it is 10:02 a.m., so I think we should go ahead and get started. Folks can just join in as we get going here. I'd like to take this opportunity to thank you all for attending this webinar. My name is Emma Perez-Singh. I'm the Administrative Manager for the Continuum of Care with the Department of Housing and Workforce Solutions. And it's my pleasure today to introduce our speakers. And before I do that, I just want to note that the purpose of these webinars are really to provide an opportunity to engage with our local and regional experts on best practices. And it is our desire to provide you relevant, up-to-date information and information that you feel is germane to the work that you're doing on a regular basis. And with that, please feel free to provide feedback and suggestions. We are always open to hearing from you. We have a email address that you can share that information. You can also reach us directly if you'd like, and we will provide all of our contact information along with the webinar materials at the very end. But again, we welcome the feedback. We love to hear from you. And, if you feel like we're doing a terrible job, please let us know, because we'd love to hear, and we're all about improvement here at the COC. So please do share. So it's my pleasure to introduce our first speaker, Ben Haudege, who is the manager for Inland Empire Health Plan, or IEHP, here in the Inland Empire. And Ben is the manager of the Behavioral Health and Care Management Support Services. And the goal of that unit is to improve the coordination and management of medical, behavioral, and social services. Ben, are you on? You can go ahead and unmute yourself and feel free to begin your presentation.
Thank you. Good morning, everyone. Thank you for inviting me to present this morning. I look forward to presenting with Nadine today. And before I begin, I'd like to, when I was asked to present about chronic illness, this video here I'd like to share with you really quick, just really came to mind about the work that we do with people with chronic illnesses. So we're going to show you a quick video, and then we'll start the presentation.
Can everyone hear it? Okay.
When you click to share the screen, I believe you have to click a button that says you're going to share audio also. You may have to unshare the screen, then share it again, and then show the video.
Pause this.
When you click the arrow, it'll be a question there. Do you want to share your audio also? Just make sure you click yes.
Can you guys hear the sound?
No.
Bear with me a moment. Yes, please.
While she's doing that, I can share a little bit about. I can share a little bit about myself, the manager for the Behavioral Health and Care Management services at IEHP. So within Behavioral Health and Care Management, we have a supportive services team, multidisciplinary team that supports the nurses and social workers that are part of the department. And so we have a housing team as part of the supportive services team. We have a long-term service and supports team. Then I also have some county liaisons. Since we work so closely with county departments, we have liaisons that work with those programs. So we'll be starting shortly here.
We're ready, Ben.
Okay, go ahead and play.
Can you hear it now?
Yep.
Antes me ganaba esto diario y ahora me gano esto diario. Hey.
Thank you. This presentation is not sponsored by that advertiser. Compassion, that's what that video is all about, and providing services to folks who are going through crisis, going through medical complications, and supporting them through all of that. That's what our Behavioral Health and Care Management Department does at IEHP. Whether the members get care directly through their Independent Physician Association, their medical group, or through us. We hope that compassion is communicated to all of our members. So today, we're talking about chronic conditions. We can go to the next slide there. I hope that video touches you and gets us to think about all the support that people need, and even during COVID times, right? And what can we do to support them? What can we do to support people with chronic illnesses and all that they may be going through? A little bit about IEHP. IEHP was created by Riverside and San Benito County back in 1996 as a public entity to provide Medi-Cal benefits and services and programs to Medi-Cal beneficiaries. So we were created by the two counties. We are a public entity. We like to say we're like a cousin to the county, but we're not county employees. And so our board, our governing board, is comprised of 4 county board of supervisors, so 2 from each county, and 3 appointed members from the public. Currently, we have about 1.5, a little over 1.5 million members, which is about 25% of the Inland Empire. That's significant. And of those 1.5 million, about 31,000 have Medi-Cal and Medicare both enrolled with IEHP. Next slide. So behavioral health and care management, the department, the goal of the department is to improve the coordination of medical, behavioral, and social services. So we'd like to and want to address the entire whole person, and by that we mean the physical health, the cognitive health, behavioral health, their spiritual health, their social determinants of health, and functional health. And I'll show you some examples of that along the way. Next slide. Here are some programs and services just to kind of get you thinking about what we do. It's a long list and we do a lot. Care management is the basic one, right? Behavior, whether it's behavioral health or just complex case management, we do it all. So case management, behavioral health care management. We have a crisis call triage and intervention call center. We authorize behavioral health services. We have inpatient authorizations. We authorize outpatient, intensive outpatient, partial hospitalizations, skilled nursing facilities, ECTs, detox, eating disorder admissions. So we have a team here that works and authorizes those, make sure folks are getting the services that they need. We do a health risk assessment or we receive a health information form that members fill out, and that's how services typically begin. We begin by everybody that's enrolled, everybody that's new gets some type of assessment questionnaire, and that's how the case management begins, right? If they have chronic conditions that we've identified, that's when typically the entry into our behavioral health care management services. We have interdisciplinary care case conferences bi-weekly. We also have a BH hospital triage and transition of care team. Community supports, I'll be talking a little bit more about that. CalAIM community supports, I'm sure you've heard of that. I'll be talking about that. We also assist with long-term service and support. So seniors and people with disabilities that need services in their home to support them in the home and live there as independent as they can with support services. And then coordination for pain management, eating disorders, or behavioral health treatment. Next slide. I will not be touching on all of them. Today, again, it's just to focus on our chronic members with chronic condition support services that we may have for them. We have new CalAIM community support. So I just wanted to touch on these really quick because there's a lot of interest in learning about these. As of January 1st, the state Medi-Cal has allowed us to provide these new services, which is great because we'll be able to support our members who are at risk of homelessness or experiencing homelessness. For example, we are now able to pay for housing transition and navigation services, meaning help finding a place to live, house tenancy and sustaining services, so that's a case management program to help people who are at risk or homeless, those who may need, similar to intensive case management services. If you've heard of ICMS, housing tenancy and sustaining services, very similar. Housing deposits, we are now able to help pay housing deposit. So whatever the deposit is, whether it's just a security deposit or first month's rent, last month's rent, we are able to pay that also if member meets criteria, of course, for all of these. There is criteria. I'll talk about that in a little bit. We do not pay for rent. We do not pay for rent, but what we can do is provide them with that case management that they may need to help them apply for benefits, get the most out of their benefits, apply for CalAIM and things like that. And hopefully they are able to rent an apartment on their own. We also provide recuperative care. If you know somebody who is experiencing homelessness, they go to the hospital, they're exiting the hospital, it's safe to discharge, but they need a place to recuperate, a place where we can send a nurse to check in on them. We have recuperative care sites throughout the Inland Empire. We can send them and they can spend up to 90 days there, recuperating, getting better, receiving health services, social services, visit from a nurse, and so that way they don't go back into the hospital. In addition to that, very exciting, we have post-hospitalization housing available. It is at the same location as the recuperative care site, so basically if they meet criteria, they can stay an additional up to 6 months with the intent that we are going to authorize more services, right, like the housing, tenancy, and sustaining services to hopefully help them to get housed and or find some type of voucher program. Always looking for vouchers and other programs that they may qualify, emergency housing vouchers, 811 program vouchers, tenant-based assistance vouchers, and other vouchers that may be available. We also have nursing facility transitions and diversions to residential care facilities for the elderly or assisted living facilities and adult residential facilities. So if somebody's in a facility, nursing facility, they're ready to get out. They don't want to be there. They want to go home, but they're not able to go home because they wouldn't be safe. They need a caregiver 24 hours a day. We can help them get to a residential care facility for the elderly or adult residential facility. We can also help them to go home. Community transitions to independent living. That means we help them find an apartment. We help them with that transition of setting up their benefits, their public benefits, or income, finding income, getting back their income from Social Security, and helping them transition to a home. Sobering centers, very exciting. We have sobering centers. So that is for folks who are out in public possibly and need and have an encounter with law enforcement. And instead of sending them to the emergency room, instead of sending them to jail, we can send them to a sobering center where they can stay there a few hours and sober up and get social services if needed while they're there in connection to programs once they leave the sobering center. That is only temporary. For a couple of hours. Again, it's not housing, it's not a facility, it's a place for them to get sober and hopefully get linkages to services after that visit. We can also do environmental accessibility adaptations and or also known as minor home modifications. This is exciting also. We can pay for ramps. If somebody uses a wheelchair, they cannot get into their home. If they need doors that are wider because now they use a wheelchair, if they need grab bars in the bathroom to make it a little bit more accessible for them, we can cover those. And we also have asthma remediation. All of these do have eligibility requirements. Typically, again, the first one is they must be at risk of homelessness or experiencing homelessness. If they don't meet that criteria, they will not be able to get these services. Another requirement is that they have to have a substantial barrier to housing. That could mean something, someone who is recently incarcerated and now they're out and they have nowhere to go. We could possibly assist them. Somebody who is fleeing domestic violence or trafficking, we can assist those folks also. Anybody with a chronic condition, multiple chronic conditions, folks with behavioral health conditions, severe mental illness, we can assist those. Former foster youth. Transitional age youth also who are exiting the foster care program, we can definitely assist those also. And I might have missed some, but we can definitely share this PowerPoint with you, and I can answer any questions if I missed the population there. Next slide. So just to show you an example of how we, the health plan, helps members, here's an example of a family or a group. Sean needs new medication. So occasionally, folks run into they have a new diagnosis, they need a medication, and they run into issues with pharmacy or something, or they need home delivered medications, we can help them, connect them to those services, even home delivered medication. Stella needs a caregiver. So we work with the county IHSS program and in-home supportive services program. We have an MOU, memorandum of understanding, with them. We work very closely with them and refer members who may need a caregiver. Or we also provide caregiver support services. So if a caregiver is finding themselves, burned out, they need a break, they need respite, they need other services, we can assist them with that. Doctors call us regularly. Maybe they can't get a hold of a member. Maybe they need higher level of care for somebody. We work with doctors to care for folks. If Raul needs behavioral health services or has a severe mental illness, we work with our providers and or county providers. The county provides some mental health services, and then we provide others. We would help Raul find the right services that he needs. Vicky is enrolled in care management, which means she gets regular phone calls from a nurse or a social worker. Our nurses are registered nurses, LVNs, licensed vocational nurses, or licensed clinical social workers, and they would call her regularly or as needed to check in to see how she's progressing on her plan that's developed once she's enrolled in the case management program. If Isaac needs any outside services like California Children's Services or any other county program, we can assist. We have relationships and collaborate with many county programs. If there's a county program out there, we probably work with them already. And if Sarah needs her vaccines, she's going back to school, but the doctors filled, with appointments, they can't get in on time. Well, we can possibly get her into another doctor within that same medical group, so we can help Sarah get the vaccines that she needs to get to school. Next slide. That was just an illustration of how we assist our members. So how do we coordinate care? A little bit of, and typically behavioral health care management, case management, typically is for people with chronic conditions, folks that have maybe a new diagnosis or a chronic illness that is uncontrolled and they need help. They need the help of a nurse, of a licensed clinical social worker. And so that's what case management is about. It's about helping folks to help them manage their own diagnosis, learn about it, educate the member about their diagnosis so they can better manage it and prevent unnecessary, unwanted hospitalizations and ER visits and things like that. So we can help coordinate services by just if somebody calls the health plan, they say they need help, we're going to help them, right? So anytime anybody needs help, they can call and somebody, a care coordinator, will assist them. Others, they may call and they may need or identify themselves as having a chronic condition, or we may ask about chronic conditions. We identify that they do meet criteria for our case management program, we would enroll them in our case management program. So if somebody just needs care coordination, they don't want case management, they just need some help, we would do that. And that means help with navigating health and social services, and also assessing for services, products, and other procedures that they may be entitled to. Now, if they want case management, they qualify for case management, they have a chronic condition, they have diabetes, congestive heart failure, any number of high blood pressure, things like that, and they're uncontrolled, they need somebody to assist. We would do an intake, we would assess them, there'd be some care planning, there'd be some goals set up, and we would assist member-centered goals. One of the questions that I love on the assessment is, what do you want to work on? What are your goals? What can we do to help you and assist you? And many times, it's interesting, it's not about health. It's not about, I want to lower my A1C or my blood sugar levels. Many times it is about social services and meeting the basic needs. So I love that we're assessing and asking that question, because that's where we identify people who need housing services and other social determinants of health needs. Once they're enrolled in the program, we do some outreach calls, either annually or semi-annually, quarterly, monthly, or as needed. At the very least, I would say most people get a call at least once a month to check in on them, make sure that they're, following up on their care. If they need help at that time, setting up appointments, setting up transportation. Transportation, I don't know that I mentioned transportation. Our care management team also helps folks who don't have transportation get transportation so they can get to their medical appointments. And educating members on the disease process, that's probably important, right? Somebody with a new diagnosis, they need to learn and know and understand how diabetes affects them, for example. nurses can do a great job of educating them and helping them to understand that. So it's about monitoring, it's about managing that chronic condition. Next slide. We have a couple of pilots. I just wanted to share exciting pilots that we're doing with folks with chronic conditions. I won't go over all the details, but just know that we're working to improve and identify programs that are evidence-based and really addressing the needs of folks with chronic conditions. For example, this congestive heart failure project, we enrolled 100 members with heart failure to participate in a 6-month program. Folks enrolled in the program received medically tailored meals for 3 months, 3 meals a day. They got a registered dietitian coaching, a new weight scale, frequent outreach from one of our care managers. They all were screened for food insecurity. Overall, we delivered over 25,000 meals, over 1,300 coolers. We did over 1,200 safety checks, provided 75 nutritional counseling sessions, and delivered over 700 produce and pantry boxes to these members. Next slide. We also have a homebound pilot, and this is for folks obviously that cannot leave the home. And so this homebound program is trying to identify how to best serve folks who are non-ambulatory and make it, have a difficulty leaving their home and receive services. Because of time, I'm going to skip over to the next slide. End-stage renal disease, also monitoring that and helping folks with meals and conducting food insecurities and coordinating with dialysis centers, very important. Next slide. So that was the pilot programs that we have. Just know that at our behavioral health care management team, we have a multidisciplinary team that includes the members part of the care team, of course. They're part of their caregiver or designee is a part of it. They're invited to participate. We have care coordinators, community and housing navigators, community health workers, behavioral health specialists who are at bachelor's level. Behavioral health specialists. We also have care managers at a licensed vocational nurse level, registered nurse, masters of social work, licensed marriage and family therapists, and licensed clinical social workers. Next slide. So we're definitely integrated when it comes to social services, medical services. This is just an image of what case management process looks like, right? Somebody calls a plan, we identify them as having a chronic illness, we'll do a bit of screening, we'll do intake, screening, then we'll, assess them, more assessments, in-depth assessment, and then care planning, develop some goals of how we're going to help people through their disease process, learning, and management. And then, of course, implement some interventions, which could be medical, they could be social, they could be long-term service and supports. All those interventions are addressed in the care plan. And of course, at the end, there's an evaluation and a discharge once they get better. Some people get better in, a couple of months. Some people takes a year, 2 years, however long it takes to meet those needs. We enroll folks in that care management process. Next slide. I see a question there. I hear that IHP now gives bus passes even electronically on their phone. Can you talk about that? Good question. I haven't heard about the electronic bus passes, but I do know that we do provide bus passes. I'd have to get, I want to give you the correct information. So what I'll do is I'll take that question back and reply in an email if I don't know the exact, I don't want to guess or give you the wrong information. Which company do we use for meal program? I believe we have 2 agencies. I'm not sure. I'll have to look at that. I think Mom's Meals may be one of them. What's the first step to get someone enrolled? They just simply call IEHP. If they have a chronic condition, call IEHP Member Services, let them know that you're interested in enrolling in the care management program or behavioral health care management program. Somebody will assess them and screen them and then enroll them in the program if they meet criteria. Is it possible to get a copy of this PowerPoint? Absolutely. We'll make sure everybody gets it after this. Just a slide on coordination. We coordinate with a lot of partners. I see a lot of partners on the line there. I see Gary Madden, Michaela, and I see others, community partners. Good to see you. But we partner with lots of folks. Inland Regional Center, of course, our doctors, our providers, and medical groups. State contracted Medi-Cal waiver agencies, county departments, homeless services, housing authority, behavioral health, aging and adult services, Children and Family Services, and of course, Public Health. And then you'll see some logos there of even some community-based organizations that provide our services. Let me back up a bit to where I was saying the homeless housing services that I mentioned. Most of them, the CalAIM Community Support Services, most of them are provided through one of our vendors, contracted vendors, like Jewish Family Services, like Lighthouse, and others, Helping Hearts, Elimination Foundation, Martha's Village and Kitchen, Step Up on Second. Most of the community support services are provided through our contracted vendors. If for some reason a member doesn't meet criteria for those services, they're still going to get services through my team, the housing team. And so just know that if they don't meet criteria that I've talked about today, they'll still get the services that they need. Next slide. Oh, I am at the end. Because of time, I don't know that we have time to answer all the questions, but definitely would love to answer your questions afterwards. I did not talk about enhanced case management today. Nadine and I talked before, and we thought it best to just have one person talk about ECM. But just know that enhanced case management is provided by Molina, and it is also provided by IEHP. So I'll be available to chime in, but I'm going to let Nadine talk more about enhanced case management. Thank you for the opportunity to speak. I'll provide my email address. If you have any questions, feel free to email me. Or if your agency is interested in a presentation, always available to help also. Thank you.
Thank you very much for that presentation. I do see there are several questions in the chat. Just want to say this presentation is being recorded, and we, with the speaker's permission, of course, can also send out contact information or relevant contact information at the end of the webinar. So we will follow up with those individuals as well. So our next speaker is Nadine Khan, who is a program director for Enhanced Care and Management. And Enhanced Care and Management also provides community support and speaks to benefits specifically for homeless individuals. Nadine, please feel free to unmute yourself, and I see that your presentation is up, and you can go ahead and get started.
I'm all set. Good morning, everyone. Happy Wednesday. Great job, Ben, on your presentation. We did take a look at our slides yesterday and realized that many of them were the same. So we didn't want to bore you today with the same two presentations. So anything that's still in mind, I'll skip over and say we covered it, but let's get going with enhanced care management, and then we'll go through those community support slides at a higher level. So what is ECM? So ECM is a statewide enhanced care management benefit that provides a whole person approach to care that addresses the clinical and non-clinical circumstances of high-need Medi-Cal members. So the program is actually a combination of the previous Health Homes program and whole person care pilots that have been in place. So those two programs sunsetted on 12/31, and then right on January 1st, we began with ECM. So those members who were previously in those two programs were grandfathered automatically into the ECM benefit. Next slide, please. So our care management models, as Ben was describing the care management programs, we still have our internal Molina case management, different levels of case management programs that the members could be in. Members could be in our basic care case management program where they need maybe a few touches of assistance. Maybe they need to be connected to providers. Maybe they need some DME assistance. We have a complex case management program where those members are newly diagnosed, or maybe they've had that diagnosis for years, but they're not managing that diagnosis well, where they need much more assistance, and the time in that program may be lengthier. Very robust care planning, interdisciplinary care team meetings, making sure that those members' needs are met. Maybe they do also have some social determinants of health need in there in combination with some chronic conditions. What's special about the enhanced case management is that they're that top layer, the most intense, because in addition to those chronic conditions, there's a lot more social impact happening in their cases. So enhanced case management, it is the most intense, and it is to be delivered in the community by community-based providers who are well-versed in that community, who may be neighbors with our members. They live in the community. They can meet in the home, in their home or in their environment, or wherever they are. You're going to where that member is and experiencing their experience, really uncovering what that individual needs to be successful and to moving forward, navigate their own care, their own life, and really just be successful as a whole person. So that's that enhanced case management. You think about it as like the top of the top needs, the complex case management kind of coupled with more of that social determinants of health need, where in-person assistance, boots on the ground, eye to eye management would be most successful and beneficial for that person. Next slide, please. Here again, so the framework of that enhanced care management program, it's whole person centered care, interdisciplinary and team-based, coordinated wraparound services and in-person services for physical, mental, behavioral, social needs. The expectation from the health plans with our ECM providers is really to have this interdisciplinary teams. There's been a lot of communication between the health plans and their ECM providers with how that care is going to be delivered. What's the expectations? What do their teams look like? What populations of focus can they serve, best serve for those members? A lot of communication and teamwork in identifying the types of members that would be most appropriate for this program, so those members are most successful and we have the correct, most appropriate team and ECM provider assigned to help those members. Next slide, please. With ECM, it's important to note that if a member is assigned to an ECM provider and is in the ECM care management program, they're not able to be assigned to our internal Molina case management program. It's considered duplicative. So when we do identify those members, we want to make sure that that ECM provider is most appropriate to serve that member's needs, because the case management program in the health plans will not be able to co-manage that member. My team, as the ECM director, and I do have 2 managers and 2 coordinators, we support the ECM providers. We will continue to meet with them and to have sort of case conferences. However, that co-management that was in the previous programs with whole person care and health homes, that is not allowed in this program. It is considered duplicative by DHCS. In addition, this slide here, it's all blue and sort of hard to see, but it is very helpful. It lists different programs and whether or not if a member is in that program, whether they can have ECM or have both. So this light blue are programs that are considered, ECM would be considered an enhancement to that program. So they could actually be in both programs at the same time. But of course, we'd also want, if they are in two programs, want to have good communication between those case managers in those two programs to make sure there isn't duplication of services occurring. The medium blue here are programs where the members could be appropriate for both programs, but they can't be in the program at the same time. And the third one here, this darkest blue, those are programs where ECM members would be excluded from those programs, just not appropriate for that membership. Next slide, please. ECM, we do have populations of focus. So we started off in January 1st, and then there'll be, in 2023, there'll be additional populations of focus added. So individuals experiencing homelessness, high utilizers with frequent hospitalizations or ER visits, individuals with serious mental illness or substance use disorder, and other health needs, and then individuals transitioning from incarceration is specific to Riverside. So the health plans are tasked with identifying these members that are within our own population, creating targeted lists of members, and then assigning these members that we identify to the most appropriate ECM providers who can service them the best, again, in the members' communities. Next slide, please. So just to go a little bit into each of those populations of focus, the first one, homelessness. So these are individuals experiencing homelessness and having a complex condition with an ability to successfully self-manage, for whom coordination of services would likely result in improved health outcomes and or decreased utilization of high-cost services. Next slide, please. DHCS also has a very specific definition of homelessness that the health plans are to follow in identifying the members for the population of focus. So these are members who lack adequate nighttime residence, a primary residence that is a public or private place, living in a shelter, exiting an institution to homelessness, who will eminently lose housing in the next 30 days, unaccompanied youth and homeless families and children of youth defined as homeless under the other federal statutes, and victims fleeing domestic violence. So this is actually the only population of focus where for 2020 we will include youth. Next slide, please. And youths and adults transitioning from incarceration, having at least one of the following: SMI, SUD, chronic diseases, intellectual or developmental disabilities, traumatic brain injuries, HIV/AIDS, and pregnancy. Next slide, please. So like I touched on earlier, members who were in the Health Homes program and whole person care as of 12/31 were automatically enrolled into ECM as of 1/1. Those include members who are in the process of enrolling as of 12/31. So if those programs had the members assigned to them for outreach and we're in the midst of outreaching, we also did include those members, so there weren't any gaps for those members that were appropriate for those programs. The grandfathered members were not required to meet one of the 4 ECM populations of focus at this time. In 6 months, they will be reassessed, and then they will have to meet one of those populations of focus to continue in the program. Okay, and then we jump into community supports, which Ben did such a great job in going over. So we'll go over these in a high level. So the community supports are supports that are focused on addressing combined medical and social determinants of health needs, and to avoid higher levels of care or other future caring costs. Next slide, please. There were 14 community supports that DHCS offered health plans to begin with as of 1/1, or the ability to roll them into their plan through some time. Next slide, please. So Molina chose to start as of 1/1 with housing transition navigation services, housing deposits, housing tenancy, recuperative care, community transition services, personal care and homemaker services, medically tailored meals, sobering centers, and asthma remediation. There is eligibility criteria to be able to receive one of these supports only, or could be partial duals member with Medicare Part B and or D. There are referrals to be submitted to the health plan, and the health plan team, community supports team will review those requests and treat it as an authorization process. So each community supports has a specific criteria in order for those members to be approved for that service. And again, in that review, part of that review is to ensure that there isn't duplication of services and that the member is not receiving those services through another avenue, such as a state or community or county funded program. Next slide. Thank you. Housing transition navigation services. This assists with obtaining stable housing. And here are some of the interventions. I know Ben went over some of this already. Next slide, please. And housing tenancy and sustaining services. Important to note here that these services are only available for a single duration in the member's lifetime. And that is the communication that we do give to members. Services may be approved one additional time with documentation supporting change of conditions. But again, that's a maybe. So we want to make sure when we are identifying members for these supports that they're aware of that, and that this is the one time that it would be most helpful for them, and they've really gone through other avenues of support to meet their needs. Next slide, please. Housing deposits as well, as Ben stated, there is a max of a total lifetime amount of $5,000. And again, here services may be approved one additional time with documentation as to why the housing deposits would be more successful in a second attempt. So in communicating with members in regards to these services, we always want to make sure that that is understood. But it's just for the deposits. Like Ben said, we're not able to cover rent fees. Next slide, please. Community transition services. So these are services with members who are have been living in a skilled nursing facility and transitioning back into their community. It is important to note here that there is a total lifetime maximum amount of $7,500. And there could be an approved one additional time, but that max is always going to stay $7,500. Next slide, please. And sobering centers, we have in Riverside only. So that's just wonderful. You know, so many members may just be having a rough night or going through a rough patch, and we don't want to You know, we don't want to see them thrown in jail or just brought to the ED to sober up. We want to see that they are going to a sobering center, and we're in Molina is searching for additional partners for sobering centers too, to expand that service. Next slide, please. So how to refer a member? You can always call in to our member services team. Also on our website, hopefully today, the actual form will be listed. We've been emailing out the forms to providers, but the form has been approved by communications and going up on the website under our referrals tab. And those referrals can be sent to these email inboxes here. I would like to point out for community supports, there are specific referrals for each of those community supports that we offer, because they do go through a referral and authorization process. So those Molina specific community supports referral forms will be important to complete and submit. For ECM referrals, we will take those as just a regular old email. We do have a form, a referral form that we would love people to utilize. So we can start with the best information and start with the most upfront member contact information. However, we will take them however you get them. If it's on another type of referral form, or just the member's information with something about how they're meeting the program, what population of focus you know they meet, or what they need help with, that would be great just to receive in that referral, and that can be emailed right over to us. I think that's it. Do you want to look at questions? Okay.
We did have a couple of questions in the chat box. One asked, please list all Medi-Cal managed health plans in the IE, and that is these two, IEHP and Molina. And then how many managed Medi-Cal members are in the IE? Do either of you know?
In IE, I would have to take back just to confirm. I don't want to throw out a number there, but I can provide that later this afternoon.
Okay, and then how many Medi-Medi?
Numbers.
Okay.
For those.
All right, thank you both. And do you have those referral forms available yet, Nadine?
I can email it out. It will be hopefully today. It's going up on our Molina website, and that would be great just to provide a link just in case there's any updates. But I can send out the current referral forms that we do have. It would just be as an email.
Okay, and then I will post a copy of that once I receive it from Nadine. I'll post a copy of that on our website along with the presentation and video.
Regarding the question about how folks in fee-for-service Medi-Cal get coordination, if they're in fee-for-service, they're not enrolled with a health plan, they do not receive care coordination. The purpose of health plans is to provide care coordination. So if somebody does not have a health plan, I'm trying to think, I would think probably the only way to get care coordination with fee-for-service Medi-Cal is if you're receiving services directly from a program, and that program would only provide care coordination for that program only. For example, Riverside County has the Targeted Case Management Program for folks that have Medi-Cal. If they meet their criteria, they would provide care coordination, again, only for that program though. They wouldn't provide care coordination for all Medi-Cal services.
That's right, Ben. So that is a gap that's been identified, especially for members who are transitioning maybe outside of incarceration. that period of time when they're transitioning, they are not always assigned to a health plan. If you're not assigned to the health plan, you are not eligible for ECM. So there may be a gap in time to where they are assigned and can be eligible for the programs. But like Ben said, fee for service, if you have a case manager, it's most likely specific to a very specific program that you are assigned to. So the best way to get assigned is you can request to be assigned to and choose a health plan.
Since most people are required to be with a health plan, actually, I'm trying to think, it's a very small group of people that don't qualify or don't have to enroll with a health plan. But for the most part, everybody does have to join a health plan. So there's very little people who are fee for service not receiving care coordination. That's the good news.
That's right.
All right. A couple more quick questions before we run out of time here. How long does it take to receive a call once a referral is received?
We are turning those around. It was the beginning of the program, so there was a lot of work has been done with the grandfathered members, but we do hope, I mean, within a week. Right now, we're shortening that time frame as we go. We would like them expedited and being able to contact that member and assign them to an ECM provider right away.
All right, and one last question. ECM is a wonderful program. What do you anticipate is your biggest challenges?
I can answer for me. So before I was a director of ECM, I was a director of complex case management. I think for the health plans, it's different to have outside entities managing the members. You know, we're going to try our best to support those ECM providers in managing our most complex members. And I think that communication is key. So I always think communication is key and always the biggest challenge. So we want to keep that line of communication for all of our members with ECM providers who are, you know, they're not staff of Molina. So it's a partnership, and it's a lot of teamwork, and it's a lot of communication and making sure that we work together to support our membership.
I wanted to add about the referral process. If you refer somebody to us, it may take 5 days for us to respond. If the member calls the health plan, they're going to be assisted right then and there on the phone. Hopefully resolve that same phone call, if not soon after that. So I would suggest if the health plan member is in need of something, has questions, direct them to the member services number, and they could direct them to the right person, right department. I would suggest that if they have an immediate need, something right away, or talk to their provider, their doctor. It's always better to talk to the doctor first, because the doctor can initiate a lot of services. But I would say if you send us a referral, we would probably respond. You know, typically we do respond within 1 day, but I don't want to say that. I'll say 5 days. To make sure we get to you on time. I would say 3 to 5 days, but no more than 5 days. Every case is touched within 5 days. But if a member calls in, they will hopefully be helped on the phone right away, and or somebody would follow up. Sometimes it does require a lot of coordination, and they have to tell the member, I'm going to work with these agencies, and we'll see what we can do to help you. So.
All right, and we've got about 1 more minute, so I'll ask these last quick questions. Do you notify the agency who makes the referral that outreach has been coordinated?
Yes, we do circle back with the agency or the referring entity just to give a high level. We received it, outreach has been made.
All right, and how do we know what program a member is enrolled in?
If you were to call into our member services team can see that. It can see what programs they are assigned to, including ECM, and if they are receiving community supports as well.
I would like to add, if an agency contacts or refers somebody to us and we don't have a formal relationship with you, I may not be able to respond to your referral. So just please know that regardless if I reply or not, we will make sure that the member is assisted and followed up on. If we don't have an agreement with you, we still receive those and assist members as needed. It's just we can't communicate with folks that we're not authorized to. But if you're a contracted provider somehow, county agency that we have a memorandum of understanding, absolutely, we can loop back and let you know the outcome.
All right. And being mindful of time that a lot of people might have meetings at 11 o'clock, we'll go ahead and excuse everyone. But if our two presenters can stay on and answer any questions, lingering questions that people might have, I'll go ahead and let everybody else go and enjoy the rest of your day.
Thank you, everyone.
All right, I do have another question in the chat box that is quickly moving. Hold on. Do you find that members reside in multifamily housing? An example, low-income senior housing, are members grouped in buildings? I ask because of efficiencies of home visits in a few buildings versus geographically spread out.
Just to understand the question, we do identify members who are maybe 10 or more individuals in one address. They're not all of our members.
Yeah, I would say we definitely do find that, and it's helpful when we are in that we can do home visits. Definitely, yes.
And then someone asked Nadine for your contact information in the chat box.
Okay, yeah, like that.
It's a question that says, what referral communication of status software are you using? I'm not sure I understand the question. Maybe you can clarify that question a bit. I'm not sure I'm understanding.
Hi, this is Ayako Tsumi asking the question. Thank you for a very informative presentation. Yes, so ECM, now you're coordinating dozens, if not hundreds, of organizations that are playing some small part in the care of a single individual or multiple individuals. So how is everyone, I'm just thinking, what were the actual logistics of communicating, sharing information, ensuring that referrals were completed, that the status of where the referrals are, did it get dropped? How do you know that everything is getting coordinated? What software platform are you using to get so many disparate organizations that are not on the same communication software to then be coordinated where everyone can very easily find the status?
Yeah, great.
Without
question.
a lot of, without a lot of extra phone calls and man hours just making phone calls. Yes.
Yeah. Well, that's definitely what's been keeping us up for the past 6 months, right? Is getting those programs and reports and systems together. Many of our ECM, the majority of our ECM providers utilize our internal case documentation system, which is a lifesaver for us. Everything that our case managers can see, our ECM providers can see. Anything that's documented by the ECM providers, we can see. We run reports on all of the members that are assigned to those ECM providers. Timing of outreach for those assigned members. Have they been outreach? Has it been successful? Is there an assessment on file? Was the assessment done timely? Is there a care plan on file? Was the care plan done timely? Is the care plan not just timely, but is it robust enough? Let's go back and take a look. We're building audit tools to review what that assessment outcomes were, and is the care plan matching that assessment, and is it robust? Looking for case conferences that are documented in our system, and is that case conference done timely, and who attended, and what was said and what was discussed. We're running reports on admissions and ER to see if it's successful. So there's a lot of IT behind this program, a ton of IT behind this program. There are the program reporting requirements to the state are very robust, and includes, like I said, outreach to members, assessments completed, the ECM staffing, what their capacity is and what their ratios are, how many members are assigned, and how many members are in their caseloads, and are they keeping up with them? The oversight of this program is tremendous. And I have a very good team that I'm blessed to have, who come from strong medical case management backgrounds, who know the behind the scenes, that every little intricate step that needs to be met. It's very important because it is a lot to oversee and a lot of support for our ECM provider partnerships.
And what medical records software are you using at Molina?
We use CCA.
Oh, okay. I'm not familiar with that. Okay. Thank you. Very helpful. And oh, may I ask one more question? So what is the load per case manager? How many ECM members are there per case manager? What's the load?
Was 30? I want to say. And I think it changed.
Okay. Thank you. Very helpful. Very exciting. Thank you.
Yeah.
Thank you, both of our presenters, for hanging on for a few extra minutes to answer those questions that were lingering in the chat box. I appreciate you, and thank you everyone for attending today's webinar.
Thank you.
Thanks, everyone. Bye-bye.
Bye, everyone.